Hi, welcome back. Today we're discussing DID, Dissociative Identity Disorder. We will focus on the DSM-5-TR diagnostic criteria. So what is DID? Well, it's one of the dissociative disorders. There are 4 in the DSM, and here they are listed. They include DID, dissociative amnesia, depersonalization, derealization disorder, and then a 4th sort of catch-all, which is an unspecified dissociative disorder that we won't talk about a whole lot today. We normally walk around with our consciousness, our mind, our memory, so what we think about in terms of the past, our perception of the world, our physical body, and our emotional state, all of that kind of integrated together into one functioning system. When that sort of comes apart, when it's not integrated, that is the essence of dissociation or dissociated state. Some examples of symptoms of dissociation would be amnesia, flashbacks, numbing, and then depersonalization or derealization, which we'll talk about in a minute. There are 2 disorders, acute stress disorder and PTSD, which are closely related to the dissociative disorders, but are not the same thing. In the DSM-5-TR, they are placed next to, but not within that chapter on dissociative disorders, and that's an important distinction. There are a number of risk factors. That is, factors that increase the vulnerability of an individual to development of dissociative disorder, particularly DID. And these include things like earlier onset of trauma. So if trauma is experienced, particularly extreme trauma, is experienced before the age of 9, the earlier trauma is experienced, and the more cumulative the trauma, the more severe the trauma, the more likely the individual is to experience a dissociative disorder, including DID. People who experience severe trauma, prisoners of war, victims of trafficking, are more likely to experience a dissociative disorder. Children who experience neglect, physical abuse, emotional abuse, sexual abuse perpetrated by a parent or a parental figure are also much more vulnerable to the development of a dissociative disorder. In order to understand dissociative identity disorder, it is first necessary to understand dissociative amnesia. So amnesia, forgetting. Dissociative amnesia in particular is the inability to recall autobiographical information about oneself that is out of the range of normal forgetting, and that's really critical. It can be localized, meaning it can be related to a particular event or a period of time. It can be generalized, meaning it's an entire life or a whole series of events in a life. That is extremely rare. So now let's look at dissociative identity disorder as a whole. How do you get this diagnosis according to the DSM-5-TR? The 5 main criteria are as follows. There must be the experience of 2 or more personality states, or the experience of possession, and we'll talk about that in a minute. There must be recurrent gaps in recall, dissociative amnesia. There must be a clinically significant amount of distress or impairment in functioning. This cannot be part of a normally accepted cultural or religious practice. And the occurrence cannot be better explained by substance use or some kind of medical condition or physical condition. So let's take the last 3 first. Those are fairly straightforward and pretty commonly applied to many of the conditions in the DSM. So distress and impairment, basically the condition has to be upsetting. And generally most people who are diagnosed with DID don't enjoy the diagnosis, and it is very upsetting, and often they will minimize the presence of the condition and try to hide particularly the memory impairment. It cannot be part of a normally accepted cultural or religious practice. So there are cultures and religions where things like, for example, possession is something that happens routinely, happens regularly. And if that is the case, then that does not qualify as the diagnosis of DID. And probably most importantly, it cannot be better explained by some sort of substance use. There are hallucinogens, there are tumors, there are toxic ingestions, there are metabolic atypicalities, lots of things that can present as all sorts of bizarre things, including multiple personalities and other things, possessions, etc. Let's look now at the first two criteria. 2 or more personality states or the experience of possessions. The experience of possession is extremely rare in DID. Generally, what you would be looking at is the experience of 2 or more personality states. We'll talk about that first. Personality states does not require that people suddenly come into the office or suddenly show up at school or work or whatever, dressed completely differently, wearing a wig, speaking in a foreign accent, all of that. In fact, the really blatant switching and changing and appearing completely different is actually the minority and actually occurs very rarely. More commonly, a diagnosis of DID is made by self-report, and it's self-report of a variety of symptoms that have to do with depersonalization and derealization. They may suddenly feel that their emotions are no longer their own, that emotions come from nowhere, almost intruding in their sense of self, and that they don't own them. The emotions may start and stop from nowhere. They may suddenly feel that their speech and actions are inhibited suddenly out of nowhere, or start suddenly out of nowhere, again, without a sense of personal agency, without a sense of ownership. So all of these things, hallucinations, voices, dissociated actions, speech, intrusive thoughts, shifting in attitude, thoughts and emotions that suddenly vanish from nowhere or start from nowhere, speech, feeling detached, watching yourself from the outside, and maybe most importantly, a sudden shift in attitudes and preferences that sort of seems to come from nowhere. Agency without actually feeling ownership of their personal identity. Sudden intermittent alterations in consciousness, memory, perception, cognition, and even in sensory motor functioning, so even how their body moves, feels, perceives the world. DSM, this is specifically described in the following way: recurrent, inexplicable intrusions into the conscious functioning of one's sense of self. All of these things may or may not be observed by others. So it is certainly possible that others may see dramatic changes in the way a person dresses, the way they behave, the way they speak, changes in prosody of speech, change in accents, style, all of those things, even the use of languages. It's very unusual that a person would use languages that they did not already know, but they may suddenly have a preference for using one language over another. Generally, diagnosis is based much more on self-report than it is on observation. Criterion B, recurrent gaps in recall, consistent with everyday forgetting. So it's much more dramatic than just the stuff that all of us forget all the time. So for example, one might find themselves all of a sudden someplace that they don't know how they got there. Lapses in memory for recent events. Lapses in memory for very well learned skills. discovery of possessions that you don't recall purchasing or owning. Amnesia for travel is common. So all of a sudden waking up in the car or waking up in some other city and not knowing how you got there. Amnesia is often not limited to the traumatic event itself. So a child who is traumatized, for example, kidnapped during 3rd grade, may forget the entire year. Generally, the lapses in memory, the amnesia, is minimized by a patient who has DID, not expanded upon. They don't tend to want to focus on it. They try to. Most people who are diagnosed with DID, with non-possession form DID, do not display the really dramatic switching in hairstyles and wardrobe and accents and all of that stuff. Rather, it is in the possession form of DID where a spirit or supernatural being appears to enter from the outside and take control of the individual. In that situation, the individual behaves and speaks in a distinctly different manner from the individual's normal behavior. The identities appear recurrently, they cause a lot of distress, and can be clearly observed from the outside. Criterion D is generally not met because the appearance and the possession is often culturally or in a religious manner sanctioned. And so the diagnosis of DID is questionable based on DSM 5-TR criteria. Again, we will explore that further in a future video. For the most part, the possession form of DID is not what is typically encountered. They don't come to clinical attention because of dramatic switching in personalities. Usually they come to clinical attention because of depression or suicidality or dramatically poor levels of function for other reasons. The comorbid conditions associated with DID are, as I said, depression, self-injury, substance abuse, anxiety, and something called functional neurological symptoms. And what that means is neurological symptoms that we cannot find a neurological basis for. Seizures, headaches are very common, and something called conversion disorders. So I can't move my arm, I can't walk, I have tingling and pain in this extremity or the other, those kinds of things for which we cannot find a biological neurological basis. But that doesn't mean it's not real. Oftentimes, a DID patient will suffer with dissociative flashbacks. Almost always there is an extremely traumatic childhood history that dates back before the age of 9 and oftentimes before the age of 6 or 7. It can be physical, emotional, sexual abuse. It can also be medical trauma, a long, painful illness requiring lots of medical or surgical procedures. Oftentimes, people with DID have a very high level of hypnotizability, suggestibility. There can be comorbid borderline characteristics, obsessive characteristics, although they don't tend to carry borderline personality disorder as a comorbid diagnosis. A subgroup of people with DID also have narcissistic and avoidant traits. The prevalence of DID is really unclear. There have been studies showing that it is very, very rare. There have been very small studies showing that it has a higher prevalence, even as high as 1% of the population, but there are a lot of people who really doubt that. Typical presentation of DID is a female, age 30, with a history of severe childhood trauma, presenting with dissociative symptoms before the age of 10. She might have up to 15 or 20 alters upon presentation, but they typically fade away very quickly as treatment begins. Often there's a history of chronic suicidality and lots of depression upon presentation. There's a history of lots of amnesia. For autobiographical events, for travel, for possessions, etc. Oftentimes there's a somewhat chaotic relationship history and an unstable work history. Usually a patient like this will present for depression or an affective complaint, sometimes for somatic symptoms, physical symptoms, and sometimes for psychotic-like symptoms, hearing voices, that kind of thing. Because these patients have a lot of symptoms of post-traumatic stress, the diagnosis can be extremely difficult. And again, as I said at the beginning, it's very controversial. There are a lot of people, maybe even the majority of mental health providers, who do not believe that DID exists. And I personally am not taking a side. If it does exist, video, I am only providing the information. And if I were to state an opinion, I would say I'm probably somewhere in the middle. It's very rare. And very, very difficult to diagnose because of all the confounding factors. There's no doubt that severe trauma in early childhood does a tremendous amount of damage to an individual and creates a whole slew of problems that are very difficult, if not impossible, to tease apart. So I think what's most important is that we do treat what is there, and dissociation and traumatic symptoms are clearly there and need to be addressed. First, the diagnoses that are most commonly comorbid with the diagnosis of DID, so the things that we most commonly run into and that really do need to be looked for and also treated, are here in this slide, and they include PTSD and the depressive disorders, the feeding and eating disorders, OCD, substance-related disorders, antisocial, avoidant, and obsessive-compulsive personality characteristics, and then, as I said a minute ago, the functional neurological symptoms. And all of those things are so commonly present, they really need to be treated and looked at carefully. So what about kids? So I don't believe we can really diagnose DID in kids, and I may be alone in that, but I think they have not fully developed their personality, and we're still pretty squishy, so we can't quite diagnose it. However, children do dissociate. That's where this all starts. So we definitely need to be looking at trauma as it begins in children. It does seem that both boys and girls have about equal rates of dissociation, although girls are subjects, victims of abuse at a much higher rate than boys. Boys do seem to develop, ultimately, DID and the dissociative disorders when they are victimized at a higher rate than girls. In other words, they seem to be more vulnerable, ultimately, and that's an important point to remember. Boys and girls both have imaginary friends at a very high rate, 60, 70% and up. So when you see a child who has an imaginary friend, you don't want to think first thing they have DID or dissociation. Since DID is extremely rare and imaginary friends are extremely common, it is probably makes a lot more sense to think that it's normal first. Children also tend to personify their mood states. So a child who is depressed, for example, may call their bad mood a bully, may give it a name, may call it Charlie, may call it lots of things, and that doesn't necessarily mean they have DID, and that's an important point to keep in mind as well, since depressed children, children with depression, it's much more common than a dissociative state. Children can become very aggressive and angry, and while aggression and irritability are seen with dissociation, they are more often indicators of other things. Adolescents tend to externalize, and while dissociation can show up as suicidality, it also, suicidality and aggression and other externalizations usually indicate other things. So similarly, rapid behavioral shifts can mean dissociative states, but also can mean other things. DID has been it has been stated that children with ADHD and bipolar disorder may actually have DID. I take issue with this because ADHD is so common relatively, and I think it would be a tremendous disservice to start relabeling lots of kids with ADHD with something as atypical as DID. And I think they would then not get the treatment that they need. So I think we need to be very, very careful about that. There's a whole list of stressors that can bring on symptoms of dissociation later in life. So if you are someone who is vulnerable to dissociative disorders because of early trauma, then later in life, if you experience something like a sexual assault or death of a loved one, particularly acutely, or violent death of a loved one through murder or suicide, or a violent car accident, you may then be vulnerable to the development of dissociative symptoms. Risk factors, which I went over earlier, here's just a list again. One of the additional ones I haven't talked about is genetic. It does look like from twin studies that at least 45 to 50% of the risk, the vulnerability for dissociative disorders may come from genetics. There are certain course modifiers, meaning there are certain things that, if they occur in life, can make a person who's already vulnerable for dissociative disorders, make them more or less vulnerable. So re-victimization by a person with DID. So if somebody who has a diagnosis of DID victimizes someone then who is already at risk, the risk seems to go up. That's what the research seems to show. Very severe psychosocial stressors, so poverty, unemployment, living in a violent environment, those sorts of things, ongoing abuse and exploitation, that goes without saying because of the risk factor of cumulative violence and stress. Partner violence, so being exposed to partner violence later in life increases the risk for development of DID and other dissociative disorders. The development of substance abuse or an eating disorder raises the risk. Involvement in any sort of criminal subgroup, in particular gang involvement, the research shows it seems to increase the risk for development of DID and other dissociative disorders. Any sort of enmeshment with the abusive family of origin, so an inability to get away from and separate from a family of origin that may have been perpetrators of the abuse in the first place, increases one's risk. Over 70% of people diagnosed with DID have attempted suicide. Now, the specific criteria for the diagnosis of DID is in question, of course. As I mentioned at the beginning, there's been tens of thousands of people diagnosed since the publication of that book, Sybil, and the criteria for diagnosis are not always followed completely. And again, I'll get more into that in another video about the controversy. So it's hard to say, but there's no doubt that there is a tremendous increase in suicidality and definitely depression and other psychiatric disorders are comorbid with the dissociative disorder. So we know that this is a problem. High-risk behavior is prevalent and comorbid, so drug use and other high-risk behaviors. Other risk factors for self-destructive behavior include cumulative and severe trauma, comorbid PTSD, and other problems. And then we know that that dissociation by itself is a risk factor for self-destructive behavior. The differential diagnosis for DID is very long, and it includes all of these things. I'm not going to read through all of them, but along with these highlighted diagnoses, and all of these things are part of the differential diagnosis for DID. So clearly, this is a very complicated and very, very confusing issue, and it is extremely easy to go down a twisted path and get all muddled up. And one of the things that's happened is these sort of institutes have popped up, and these organizations that are probably mostly in very good faith trying to support people with dissociative disorders and people with DID. But what happens is if we are very interested in a certain diagnosis, and if we are really looking for it, patients can become, in an interest of making the clinician happy, they will tend to talk about certain symptoms more than others. And I think it becomes very easy to find what we're looking for. And that's a dangerous thing to do, because we can miss some other diagnoses that are extremely important not to miss. Treatment for DID is a complicated issue, is a controversial issue, and has taken many forms. What I've tried to do here is outline treatment that is focused on the things we know are problematic in dissociative patients, and that we know, at least fundamentally, is going to be helpful for generally all patients and not harmful. It has been established that a safe and therapeutic environment is generally always helpful. The treatment for patients with dissociation of any kind, particularly in a DID situation, is going to be long-term. It's going to be complicated, and it's going to be long-term. It's going to be very important that the therapeutic relationships are strong. And it is critical that the clinician establish really good boundaries with the patient. And that's probably, of all the things I've listed here, the most important. Without good boundaries, the therapy doesn't go anywhere good, and in fact can be really harmful. Again, I'm going to go into this more in another video, but that's critical. The therapist needs to have really specific training and really good training in how to deal with someone with this serious level of trauma. And that's also the next box, which we need to have specific knowledge in personality structure, in trauma, and what trauma does to a human being, to a child, and to human development. Without that specific training and education and knowledge, harm can be done, and very serious harm can be done. So those things are the basic tenets. Without that, there's nowhere to go. There has to be a no harm, no self-harm contract in place. And I think that is critical also before therapy even begins. Otherwise, a therapist can wind up feeling held hostage to demands that a client, a patient can make. Generally, it's accepted that there should be a working through of the traumatic and dissociated material. So generally, there has been a trauma or lots of trauma over time, and that material, those memories, have been encapsulated in some way, and the patient has put them aside, put them down inside somewhere, and is protecting against them and doesn't want to deal with them. And that's how the split off pieces of personality have kind of come about, is in a protective way to not deal with the memories. So the next step then is working with the alters, or working with the fragmented pieces of personality, not against them, but with them, in order to allow the individual, the self, to process those memories. And the goal would be then to develop more mature psychological defense mechanisms and be able to accept the past, not run away from it, not really let go of it, but really to accept it, to accept those memories. The goal is not always fully integrating all of those personalities or all of those fragments. Sometimes it is just to develop a self that can manage all of it, like a sort of like a conductor. It really depends on the therapist. And in my opinion, there are a variety of approaches that can work and that are healthy, as long as those first several boxes are in place, as long as you have somebody who has good boundaries and good training and a good relationship with the patient, and a person who knows what they're doing. And I think it can be done successfully over a long period of time. I'm putting this slide up just to make a few comments about the research. Again, I'll do another video on treatment of DID, and we'll talk about this in more detail. There's a few points made in the research that are important. One, cognitive behavioral therapy has not been shown to be particularly helpful, nor has ECT, shock therapy. Most recently, DBT, dialectical behavioral therapy, has been shown to be helpful. Hypnosis might be useful. A particular type of therapy called internal family systems therapy has been helpful in the past, although in the past 5 or 6 years it has gained a relatively poor reputation due to a very big scandal back in 2017 around repressed memories and false memories, and we'll talk about that again in another video. There is a lot of controversy around the need for full integration of personalities and integration of traumatic memories, and whether or not that's critical. So we'll talk some more about that as well. But I do put this slide up mostly for reference. Okay, so quick review. What have we learned? Dissociative identity disorder is a very controversial diagnosis. Lots of professionals don't believe in it. Lots of professionals believe it's real, but it's very rare. And there's a minority who absolutely believe it's real, and in fact, it's not rare at all. What are the criteria to diagnose it? Well, you have to have at least 2 personalities, and you have to have a lot of forgetting that is beyond regular forgetting. In addition to that, it has to cause a significant amount of distress and impairment, and it can't be due to a culturally accepted practice or a religious practice, and it can't be due to substances or a medical condition or anything like that. So the treatments are controversial, although there's a lot of research being done, and we are starting to learn a little bit more about it. So that's it for today. I will be doing some follow-up videos exploring the controversy more, and also more about treatment options for DID. Let me know what you think of this video in the comments below, and if you enjoyed the video, please give it a like and subscribe to my channel. Hit the notification button so you don't miss anything. Thank you for listening. That's it for now, and I will see you next time. In this slide, I've listed some of the more specific treatment modalities that have been studied over the years, and I made a few comments about what I think about some of those or what the conclusions of some of the research have showed. Again, I'm not going to go in detail into the treatments, but I will in another video. There's a lot of controversy about a lot of them. I want to make one comment here, which is about something called internal family systems by a psychologist called Richard Schwartz. And this actually had a lot of popularity and probably fundamentally is a reasonably good treatment approach, but there was tremendous controversy around it about 5 years ago because of some issues around something called repressed memories. And I will be doing a video within this next couple of weeks talking about that and the validity of repressed memories. It caused a lot of people a lot of trouble. So that's an interesting topic. Currently, DBT, dialectical behavioral therapy, is getting a lot of attention and probably has a role in the treatment of DID and dissociative therapies in general. ECT and CBT have been found to be less helpful. Generally speaking, the therapeutic approach of engaging with the alters has been something that research has shown to be probably helpful, but again, it takes a long period of time and it takes work with a therapist who really knows what they're doing. Okay, so quick review. What have we learned? Dissociative identity disorder is a very controversial diagnosis. Lots of professionals don't believe in it. Lots of professionals believe it's real, but it's very rare. And there's a minority who absolutely believe it's real, and in fact, it's not rare at all. What are the criteria to diagnose it? Well, you have to have at least 2 personalities, and you have to have a lot of forgetting that is beyond regular forgetting. In addition to that, it has to cause a significant amount of distress and impairment, and it can't be due to a culturally accepted practice or a religious practice, and it can't be due to substances or a medical condition or anything like that. So the treatments are controversial, although there's a lot of research being done, and we are starting to learn a little bit more about it. So that's it for today. I will be doing some follow-up videos exploring the controversy more and also more about treatment options for DID. Let me know what you think of this video in the comments below, and if you enjoyed the video, please give it a like and subscribe to my channel. Hit the notification button so you don't miss anything. Thank you for listening. That's it for now, and I will see you next time.